Hi, I'm Alex Abbott. I'm one of Stanford Children's primary care sports medicine doctors. Before I was in the Department of Orthopedic Surgery, I was a general pediatrician. I'm excited to share some pearls from fellowship and a little bit of my attending experience on fracture management for a primary care provider specifically. My goal overall for this session is that you feel less anxious when a patient with a broken bone presents to your outpatient clinic. We'll start zoomed out with the epidemiology of pediatric fractures and with the overarching clinical principles and the themes of pediatric fracture management. I'll try to help you understand the physiology of healing bones and to gain perspective about how fracture management works. I'll also give you some practical insider tips that can help you make confident recommendations to your fracture patients. This year, I'll publish some data from the last 4 years which analyzed fracture visits in an orthopedic urgent care. Our large cohort demonstrated that the most common fracture sites were of the wrist, hand, elbow, foot, and ankle. The most common specific fracture types were the distal radius and the hand phalanx. When dissecting our data by sex and by age group, the boys and the toddlers were diagnosed with fractures most frequently. Our data is concordant with previous studies of large fracture visits in primary care, but we also contributed some practical analysis that helps you profile your patients in a sense. This graphic is really cool and sort of demonstrates what you probably already know to be true in your pediatrics clinics. Little walkers get toddlers fractures and they fall from changing tables. The school-aged kids foosh and hurt their arms and their supracondylar humeri, and the adolescents roll their ankles and fall with better coordination to hurt their more distal extremities. Our population in orthopedic urgent care was mostly pre-differentiated with a high likelihood for fracture, but you can see on the right that the more distal the injury, the greater the pretest probability was for us for a fracture diagnosis. You might consider these probabilities in addition to your clinical findings for X-ray utility. Our study also shows some cool fracture subtype nuances. The torus or buccal fractures have a bimodal distribution in our cohort. So these are the babies who are falling off the changing tables, and then later the school-aged kids who are falling onto their outstretched hands or fooshing. The green stick fractures were most common in younger children. The hypothesis is that their bones are softer and they develop over time to less likely sustain green stick fractures as older children. The Salter-Harris or growth plate fractures seem to occur most frequently in the older children, likely because that's when the risk for higher forces in your sport intersect with the still open growth plates in older children and teenagers. And then avulsion fractures, likely mainly the ubiquitous fibular avulsion fracture from rolling or inverting the ankle, were most common in teenagers. Finally, as boys and girls age, as you can see on the right, they start getting into different types of extracurricular misadventures, and boys are more likely to be diagnosed with fractures as they get older when compared to girls. We discussed profiling your patients in a sense with a pretest probability based on their chief complaint or injury site, but clinical evidence is the most important. Fractures can be obvious or subtle even when you get the x-ray. Some patients will guess that they don't have fractures because it doesn't hurt that badly, or they'll surmise that sprains hurt more than fractures, but clinical severity is generally worse for fractures than non-fracture injuries, but there's not like a point system like there is for strep throat or a septic hip to guide what your next step is, or in this case, obtaining an x-ray. I would say that the best practice as an outpatient pediatrician, if you have a suspicion for a fracture, is to have the patient obtain an x-ray and then return to your clinic for review prior to discharge home. If this is not possible at your clinic, they should present to an emergency room or an urgent care for an x-ray. When you're ordering an x-ray, if it's the initial evaluation, a complete x-ray with at least 3 views is best. as you can see in the oblique view of the hand on the right, there's an obvious metacarpal fracture, but it's not visible in the AP view at all. Once a fracture is identified, we can reduce the number of views that we're getting for follow-up examinations based on where the fracture is visualized. So we can reduce cumulative radiation for patients who need frequent follow-ups for fractures, but sparing radiation is not the best idea when you're doing the initial evaluation and you want to make sure you're not missing something. I kind of alluded to the point system, like the center score and the Coker criteria that pediatricians use for other types of problems with pediatric patients present to you for, and that there isn't really a point system for fractures. You can use this kind of MD-Calc and the Ottawa ankle rules to help differentiate clinical signs for fracture versus non-fracture just for the foot and ankle. An inability or refusal to weight bear, posterior or distal malleolar tenderness, all of those factors should prompt an X-ray for ruling out ankle fractures. Malleolar tenderness would be either medial or lateral malleolus. Inability or refusal to weight bear, fifth metatarsal tenderness, navicular tenderness, which is at the medial aspect and more proximally on the foot. Those factors should prompt an X-ray to rule out foot fractures. Again, consider a complete X-ray with 3 views for your initial evaluations. Once you've diagnosed a fracture, it's important to be specific about your diagnosis. Changing the initial appointment diagnosis from their chief complaint of knee pain to right proximal tibia, non-displaced, closed tibia fracture initial is insanely helpful for the emergency room and for their orthopedist when they present for follow-up. Even if you can't specify the fracture type or measure the degree of angulation, displacement, or shortening of a fracture, just specifying the bone, laterality, whether it's closed and open, and whether it's displaced can significantly help providers obtain the right x-rays for their patients and prepare for the patient's anticipated needs when they present elsewhere. Imagine the difference between a patient who's presenting for unspecified knee pain with unspecified laterality versus a patient whose pediatrician diagnosed their fracture as specifically as they could, presenting to the emergency room. That second patient is getting an x-ray appropriately much faster, and the ED doctor is looking for the x-ray in the chart. The patient's differentiated instead of starting from square one and reinventing the wheel, doing the work that you've already done in the clinic. And if the fracture is displaced and they're presenting with that diagnosis, the emergency room or orthopedist might be mobilizing their orthopedic technician or ortho team for reduction, sedation, splinting, whatever else the patient might need because they know it's displaced. The patient might even get pain medicine more quickly. I've had some pediatrician friends push back when I describe this difference and tell me I shouldn't have to do the emergency room's job. But making that specific diagnosis for your patient based on an x-ray is a quick step and can result in a major difference in the quality of care for your patient. It also helps your patient when they come for follow-ups with you when you see the fracture diagnosis instead of the knee pain diagnosis in their past medical history. Finally, research like the epidemiology data I showed you before is completely impossible for nonspecific diagnosis and is one of the major limitations for characterizing pediatric injury epidemiology. Vague diagnoses like knee pain or arm pain are really hard to differentiate in the literature. If patients are presenting for fracture specifically, sprain specifically, radius versus ulna, distal versus proximal, supracondylar humeral fractures, we wouldn't have any of that data without specific ICD codes being used in the United States. In kids, fractures can involve the growth plate, and specifying if the physis or growth plate is involved when the diagnosis is made can be really helpful for the follow-ups as well. We use the Salter-Harris classification system, which has a helpful acronym right in the name, SALTER. Salter-Harris 1 fractures are S straight across the growth plate and are usually not identifiable on X-ray because they're sneaky right inside that growth plate. Salter-Harris 2 fractures are above the growth plate. I remember instead of A for above, A for all of the bone to indicate the majority of the bone, or metaphysis with an A, because if you don't remember how to orient the bones with the epiphysis at the bottom, then that above clue is not going to be helpful. Salter-Harris 3 is the epiphysis or lower below. Salter-Harris 4 is through the growth plate for the T in Salter, and Salter-Harris 5 is ER or erasure of the growth plate, usually from a loading or crush injury. Salter-Harris 3 and higher are most likely to require a surgical intervention, and we do physis checks for all Salter-Harris fractures once they've been identified every 6 months for 2 years or until puberty when the growth plate's closed. This is to make sure that the fracture around the growth plate doesn't stimulate premature growth plate closure or growth arrest. A physis check involves bilateral x-rays of the affected physis to ensure that the growth plate is symmetric over time while it's still open. The physis checks are not really practical for patients that have growth plate fractures of the fingers and toes or of the distal fibula. We don't really think about length discrepancies for those bones causing an indication for surgery, like it would for the tibia or the radius or something like that, where the bone is loading and where length discrepancies can really change the function for the patient. This slide is meant to illustrate that some physeal fractures before reduction are obvious and then not apparent after reduction by the time the patient comes to ortho. The emergency room usually adds a diagnosis for displaced Salter-Harris 1 fracture. This would be the diagnosis in this case. You can see the pre-reduction films in the top and then the post-reduction films in the bottom. This diagnosis is crucial for me when patients don't carry their initial images when they've presented from an outside emergency room. But if they present to your pediatrics clinic first and you have these initial x-rays, then putting your diagnosis and changing it from wrist pain, which was the chief complaint, to closed right displaced distal radius Salter-Harris 1 fracture, and then placing the referral for ortho for follow-up after the ED with this diagnosis would be clinically excellent practice. Including the x-ray in your clinic note and in the musculoskeletal exam at the time of your evaluation would be really helpful as well. So why does it matter if the patient comes to see me with the post-reduction films and I don't know that it's a growth plate injury because I don't have the diagnosis or the hand-carried films? Specifying that physeal involvement in the initial diagnosis reduced the risk for errant lack of that physis check follow-up that we talked about. Physis monitoring after fracture healing is important, as we discussed previously, but if a patient comes to me with a reduced fracture that looks like the growth plate's not involved and they don't have a specific diagnosis on their referral, I might not realize that they have a need for physis checks in the future. These are some examples of what I might see on radiographs in the months and years after the patient's growth plate fracture has healed. On the left are Park-Harris lines, which are benign but indicate temporary growth arrest in the past. In the middle, you can see that the right distal tibia physis has closed at the medial aspect but still open laterally. This can be a normal finding, but if the growth plate was wide open on the left ankle x-ray and the patient had a history of a distal tibia fracture, I would monitor the leg length and the degree of tibia bowing with closer surveillance, and I might consider surgical intervention for any symptomatic sequela of premature physeal arrest. On the right side is an example of an abnormal physeal bar, which is most obvious in the bar-shaped morphology on the CT scan. This is a similar sequela of physeal fracture involvement. Description of all of the different fracture types is out of the scope for fracture management that I'll cover today, and you don't need to know how to describe every single type of fracture, but these are some examples of two of the most common fracture types in pediatrics. The torus or buccal fracture at the top occurs commonly in the Fuchs mechanisms, falling on the outstretched hand from the soft bone of kids collapsing into itself. You can see the wavy tectonic plate-like line on the AP view, and then on the lateral, this kind of soda can crumpling. The green stick fracture on the bottom occurs in kids' soft bones, similar to how a soft or a fresh piece of wood only cracks on one side when you try to snap it in half. Both the torus and the green stick fracture types tend to heal quickly and without complications or controversy and without any surgical needs. Some patients will come to you with fractures that require emergency room or urgent care evaluation, or their resources in those locations. Any patients that you're concerned about neurovascular compromise on exam, or who you're worried they might need fracture reduction or surgical consultation after seeing their x-ray, should present to the ED for urgent management. Patients you're worried about their neuro exam should go straight there without waiting for an x-ray, unless you have the ability to reduce and splint a fracture that's compromising nerves or vessels immediately. Some sideline physicians or physicians in a ski clinic, for example, will commonly reduce a fracture or dislocation if they can maintain it with a splint in order to transport the patient with less emergency or risk for ischemia. I would say that this should never be a concern in a pediatrics clinic, but I have heard of a kid falling on the way to their well child check and then just rolling it into the visit instead of seeking acute care. Even though patients might push back, if they need a supply or a DME that your clinic doesn't have to safely immobilize their fracture, they should present to an ED or an urgent care. This is annoying and inconvenient, but it's favorable to, let's say, weight bearing on a broken ankle for days while waiting for Amazon to deliver crutches and a cam boot. Finally, I included a photo in the middle to illustrate how benign a type 1 open fracture can look. This fracture needs antibiotic prophylaxis to prevent osteomyelitis, and no one's going to fault you for prescribing a week of Keflex for the patient to start once their immobilization needs are reconciled. I've heard of primary care doctors instructing patients to ask for a Keflex course from the ED upon discharge or from ortho when they present for follow-up, and this sort of bystander effect can lead to treatment delays and even misdiagnosis if that wound heals or if is not apparent when they present to another provider later. If a patient has an injury that's suspicious for fracture but their x-ray looks normal to you, consider Salter 1 injuries in patients with open growth plates and correlate pain location to the site of the growth plates. You can treat these fractures or concern for fractures conservatively with immobilization and then recheck an x-ray and their clinical exam in 1 or 2 weeks to confirm or rule out fracture. If the x-ray looks normal and the growth plates are closed or pain is not really near the growth plate line, you might consider asking radiology for a prelim read or a wet read to help you break the tie. Again, a non-fracture with severe symptoms like refusal to weight bear can be treated with immobilization and instruction for non-weight bearing with crutches, treating that like a severe sprain. And then if the symptoms are persistent for 1 or 2 weeks, you can recheck that x-ray to see if there's evidence of fracture healing. If the bone looks identical on your 2 x-rays after 1 or 2 weeks, then I describe to patients that there is not a construction site being demonstrated, and that helps to confirm your non-fracture diagnosis and give you and the patient peace of mind. Sometimes reevaluating just the physical exam after 1 or 2 weeks is enough, and reassuring that you didn't miss a fracture, like the patient running into the room and jumping on the exam table for their follow-up. You can rest assured that the patient walked off the fog of war of their initial injury. This patient presented in October with at his first follow-up, his x-ray was read again as normal, but there appeared to be a construction site over the top of his navicular, or the dorsal aspect of his navicular. He was tender over this spot still, but able to weight bear now. But since there's a possible fracture given the remodeling and associated tenderness, we decided to continue sport restriction and continue that immobilization with the removable cam boot to avoid prolonging fracture healing time. So this patient no longer needs the cam boot for a weight bearing issue, but we're seeing a construction site or a remodeling change over that navicular that suggests that if we don't immobilize it, we will have prolonged fracture healing. At his next follow-up, the x-ray was read with the cortical change that we noticed previously. He was still tender over this spot, and he's only 1 month out from the fracture at this point. So we just recommended continued gentle range of motion to prevent ankle stiffness, but continuing sport restriction to avoid any further damage to this healing fracture site. This is at his final follow-up where the x-ray shows the gray soft callus that you saw on the previous slide transformed into more of a bright white hard callus, which has a more solid appearing cortex rather than the hazier one that we saw previously. And the patient also had no clinical tenderness or any range of motion issues at this point. He's been back to football without issues after this appropriate 2-month sport restriction period that was reasonably needed for a foot fracture. In a primary care clinic, it's common to stock crutches for different heights, post-op shoes for foot fractures, cam boots for ankle and distal leg fractures, hinged knee braces or knee immobilizers for fractures near the knee, and slings for a short period of shoulder immobilization for clavicle fractures. We immobilize those for 2 or 3 weeks in a sling. Slings should not really be used for any other fracture type other than the clavicle and humerus, and I'll talk about a little bit about that later. In the ED, they have the tools that you need for sedation, reduction, splinting, consulting orthopedics immediately, and most, if not all, of the DME that might be needed for removable fracture immobilization. I included some examples of reasonable and impactful reasons to refer a patient to ambulatory or outpatient orthopedics when they don't need to be triaged to the ED or to urgent care first for initial fracture management. So these include if a fracture doesn't need immediate care, but it's outside of your comfort zone for follow-up and fracture management, if there's growth plate involvement, or if the degree of displacement, angulation, or shortening of a fracture is concerning, but the patient already received immediate care in your clinic or in urgent care or closed reduction in an emergency room. And then finally, if a patient receives a splint in an ED and then they will need to transition to a cast in a week. We do casting in the orthopedics outpatient clinics. So we splint the patient first and then we cast after 7 to 10 days. This allows for swelling in the less rigid splint and then helps to prevent compartment syndrome from occurring if you put on a cast that's really tight too soon after the initial injury. Regarding the second example, consulting surgery, I will show some examples of fractures that remodeled without surgery to help get some perspective. I'll also give some information about guides you can use for objective references about thresholds for how displaced is too displaced, how short, how angulated is not tolerable. OrthoBullets is a great resource as well and typically has more specific numbers than UpToDate for your quick references. Once a patient's fracture is diagnosed and immobilized, healing time varies with age and with the bone that's involved. Definitive immobilization can include an aluminum splint or buddy taping for finger fractures, removable braces or boots if the patient will adhere to continuous use, slings for clavicle or humerus fractures, and crutches to allow non-weight bearing for lower extremity and axial fractures like vertebral or pelvic fractures. Casts are needed for definitive immobilization in children who won't adhere to removable immobilization. I've had patients who are teenagers whose parents say they will play football if you give them something removable, and I've had 2 and 3-year-olds, kids that of that younger age group, who take them off on site. So those patients need casts. Most fractures heal in the range of 3 to 8 weeks. After about 8 weeks of poor healing and not really with evidence of callus formation, we start to get nervous about patients who are in casts because of the stiffness of the joints. And we start to worry that the healing process might need some surgical intervention, or maybe there is a vitamin deficiency or other organic process that's delaying the union. After 2 to 4 weeks, there should be a callus on your x-ray. There's an example of a diaphyseal left ulna fracture with callus formation on the right side of the screen. Once a callus is formed, we commonly transition to a removable brace instead of the cast to continue the healing process, but still allow for the reduction of that wrist stiffness. So they can take the splint off when they're seated or at routine times during the day to help range their wrist, but the immobilization will still allow for continued fracture healing. Younger children often surprise us and defy that average healing time frame. They have a thicker and more intervascular periosteal layer of bone, and the blood flow is what defines fracture healing time. The first 1 or 2 weeks after a fracture, the inflammation is at the worst, and then after that acute inflammatory phase, the repair phase is associated with resorption of necrotic bone at the ends of the fractures. So sometimes the fractures will look worse and more concerning to parents as that gap is widened between the bones. Immobilization during the repair phase allows for revascularization and then for cartilage to bridge that gap of the fracture. That cartilage is then ossified, which turns the soft callus into a hard callus. You can diagnose clinical fracture union when the patient is non-tender and you can see more than just black air in the fracture line on your radiograph. After clinical union and discontinuation of their immobilization, the fracture will still continue to remodel for years. Wolff's law says that the bone and bone density increases in response to stress and to load. So as the patient loads this bone, osteoblasts will build where needed and osteoclasts will remove bone that isn't needed. So you think about the apex of an angulated fracture, the pointy part, that's not really going to be needed later. So the osteoclasts will in effect shave that down and make it look straighter later. Sometimes parents are skeptical when I describe this remodeling process, and they're baffled because their child has such an ugly initial fracture, but the degree of displacement, angulation, and or shortening of the fracture is still reassuring to me. They're shocked when I tell them that the fracture will heal and remodel on its own, and they're skeptical that there won't be some kind of deformity or functional problems if this fracture is allowed to heal without surgical intervention. I often show examples of fractures after remodeling to help reassure parents and to help them reconcile why I'm so unfazed by their small, vulnerable child's seemingly horrible fracture. I'll show you some cool examples of my remodeling encyclopedia, and then that will hopefully help you get the gestalt and some context for the orthopedics clinical perspective as well. So the first set here are clavicle fractures. We typically tolerate 2 centimeters of shortening, which you measure from the end to the end of the fractures. But many surgeons will defer intervention or defer putting hardware in based on a higher threshold. But 2 centimeters is the textbook. The surgeons often will describe, especially for very young children, that there's a high remodeling potential, so they'll tolerate greater shortening based on their clinical expertise. For displacement, we use the distance between the bones. A common threshold of greater than 1 bone width is used frequently in the textbook, but again, some surgeons are more judicious about this rule as well. The clavicle fracture on the right helps to give more of a timeline. It shows that hard callus that precedes the remodeling over subsequent years that occurs in the other photos that you can see of the clavicle fractures. Again, remodeling is based on the loading. So the load vector is mainly through the center of the bone based on the muscular attachments and how the bone is physically loaded. But you see it on the bottom right, that's the a picture with the callus. It kind of looks like a circle or a knot of bone where the fracture used to be. As this patient starts loading, in order to remodel it and make it look more like the straight clavicles that you could see in the other examples, the osteoclast that we described before will detect that there's no load going through those apexes or the edges, those little pointy parts on the top and bottom of that circle, and the osteoclast will break that bone down and the osteoblasts will build up the bone in the center. Here are some humerus fractures in very young children. To contrast with the clavicle fractures from adolescence shown before, you can see that the remodeling time is shorter and the remodeled bone is harder to detect when you compare to the new and old fractures in each of these examples, mainly because these patients are younger than the teenagers who are sustaining those clavicle fractures. These are some proximal humerus fractures. The shoulder in children has a lot of tolerance for displacement, as you can see. Again, my goal is to keep children out of the operating room as possible as a primary care sports medicine doctor. I'm trying to avoid the risk of surgery and the non-union of a fracture that's been traumatized further with hardware, if preferable, because of these awesome potential non-surgical outcomes. These are some more upper extremity examples. We have the humerus on the left, proximal humerus in the middle, and then more distal humerus with a segmental fracture on the right. All have remodeled really well. I think the picture in the middle is especially indicative of how much remodeling potential and how much room for displacement there is in the shoulder. These are the common distal radius and ulna Fuchs fractures in the middle and on the right, with just a few months of remodeling that was needed for the younger children who had these fractures. Here we can see some displaced finger fractures. For these examples, it's especially apparent when a patient is young and their parent is looking at a picture of their bones and they can see the straight bones around the fracture phalanx. They can see it doesn't look straight, it doesn't look right. I need something to push those together and hold them together, or my child's gonna always have this oddly shaped thumb or deformity, and it just doesn't sit right when you have your little daughter or son who has something obvious on their x-ray and the doctor's telling you this will heal on its own. But this remodeling encyclopedia can be really helpful for that. Here's some lower extremity fractures. We have the femur, the distal fibula, and then on the right, the second through fourth metacarpal fractures. Some major takeaways, I think, from the fracture remodeling examples are that kids are awesome and fractures can look really ugly but surprise you for normal healing. But this reference can be really helpful to look up the objective, how ugly is too ugly, if your remodeling encyclopedia isn't comprehensive, if you're a new provider or one who doesn't have a great clinical gestalt yet for orthopedics injuries and fractures. This reference can tell you how displaced, shortened, or angulated a fracture should be to consider surgical intervention, and how long is too long to give different fractures to heal. I'll give two examples so you can kind of see how this field guide can be helpful for you in clinic, and it may surprise you how little reading you might need to do to manage fractures more confidently. I describe frequently, especially as a pediatrician myself, that the curriculum for pediatrics residency has a surprising lack of musculoskeletal and orthopedics education. But a lot of they describe ortho bros will describe that things are super simple and tangible, and it's never too late to learn something new. You probably rarely get nervous about upper respiratory infections, and many pediatricians use references like UpToDate to find antibiotics dosing, what's my workup for this patient with lymphadenopathy, what were the Kawasaki criteria again, etc. Using reference is common. It helps you maintain objectivity, and you often realize that you don't need the reference anymore once you start remembering the management pearls on your own. So these are a couple figures from the clavicle chapter. The format of every chapter is demonstrated here to kind of provide some textbook examples of the fracture type, and then any photos of radiographic nuances that you might it might be helpful that you're aware of. On the left, the caption indicates that the shortening for this clavicle fracture is measured at 3 centimeters, which I described was over that threshold for shortening and considering orthopedics consultation. On the right, you can see the management guideline table, which is present for every fracture site that's discussed in the reference. It starts with initial management, which is U, and it tells you that the immobilization type for clavicle fractures is sling, with follow-up in 1 to 2 weeks, and then immobilization time total about 3 to 6 weeks in that sling. After 3 to 6 weeks, the patient should have no tenderness and evidence of callus on their x-ray. Once you diagnose clinical and radiographic fracture union, the patient's instructed to refrain from contact sports for 1 to 2 more months. At the bottom, indications for orthopedic consultations start with emergencies, orthopedics needs like sending to the patient for an immediate ED evaluation. These would be for skin tenting and for open fractures. Skin tenting essentially describes a pinpoint tent pole of a sharp fracture fragment that is threatening to poke through the skin and become an open fracture. Many patients have deformity and swelling when they have clavicle fractures. This is not considered skin tenting. Non-urgent orthopedics consultation after the patient has been provided with a sling or triage to the ED or urgent care if needed would be reasonable for patients who meet these shortening or displacement criteria. For those that you want a subspecialist opinion, or for patients who are concerned about the deformity and the remodeling process. The hand chapter here highlighting the scaphoid fracture section shows a scaphoid fracture on the left and then the management table on the right again. The initial treatment is a short arm splint if the patient can be trusted with that removable brace, or a cast. So your first decision tree is, do I have the ability to provide initial management? Do you have that in your clinic? And if it's something that's not removable, then do they need to go somewhere else? So if you can't provide that in your clinic, then they should present to an ED or to an urgent care. Depending on whether it's a DME issue, they can go to urgent care, or an acuity issue like neurovascular problems or open fractures, those would go to the emergency room. The second decision is whether you can follow it, or if you need ortho to see them for follow-up. It says here in 10 to 14 days, based on your own comfort managing fractures and whether the fracture is too nuanced for your expertise and whether casting is needed. Immobilization time and healing time are estimated, and then the indications for orthopedics consult are at the bottom. Again, acuity needs for any fractures to triage to the emergency room are neurovascular concerns, infection concerns, pain control, need for reduction or splinting, etc. As you can tell, I've received some questionable referrals that have made me, as the kids say, cringe at some of my fellow pediatricians. I provide this running list of worst practices to contrast with the best practices that we've discussed so far. I feel comfortable being candid with you because I know what it's like to be in a pediatrics clinic and have a patient here for a well visit who wants to tell you, by the way, about their soccer injury last week, and you're the first doctor that they've told about it. I also hope to give some perspective about what it looks like on the other end of an incomplete referral or an inappropriate referral. A little bit of roasting of my pediatrician friends while maintaining their anonymity is fun as well. Not obtaining an x-ray before referring a patient to ortho urgently for fracture management. I think the concern is that if you check the x-ray, then you have to face the reality that you don't know how to read it, or ask the patient to do the unpopular task of waiting in the clinic for you to get to read it or to get a wet read. But think about the two different outcomes. The x-ray in the orthopedics clinic when they go back is negative and they didn't end up needing the subspecialist, but you used the resources and they had to pay a second copay. They had to drive to a different clinic and they were sitting and waiting while they were waiting for their appointment, not sure if they have a fracture or not. The second outcome is that they go to ortho and they get the x-ray and it's positive and they've been mobile with a fracture for the variable amount of time until their orthopedics appointment. Or the x-ray is positive and needs a reduction or surgery and has to be triaged to the emergency room, but they've been sitting at home or walking on it for about a week. I had one patient come to me with a diagnosed distal radius fracture in a sling. They were diagnosed by their pediatrician with an x-ray, but they didn't have any wrist protection. They just had that sling. The slings are good, like I said, for immobilizing clavicle fractures and for shoulders that are reduced after dislocation. But for a wrist injury, it's just making the kid nervous because if they bump their wrist, it hurts without wrist protection. And they get a stiff shoulder and a stiff elbow, and they have this kinesiophobia, fear of movement, where the first exam with another provider who's taking the sling off is really difficult. I think this pediatrician was trying to do the right thing and just provide them with any DME that they have in their clinic. They gave a sling, ordered an ortho referral, and then they didn't want to have that unpopular recommendation to go to urgent care for a splint or the brace to immobilize that wrist. This wrist fracture ended up needing reduction, and so then I have to make the unpopular recommendation to triage this one to the ED for sedated reduction anyway. The pediatrician received that report from radiology about the radius fracture, but also did not look at the x-ray herself. I think if she had seen the x-ray, she might have realized the need for a reduction because of the displacement and may have triaged this patient more appropriately to the emergency room. Of note, reductions go much more smoothly on day 1 of a fracture rather than day 7. The next one is hoping the patient can see ortho soon. I would say that when you consult ortho outpatient, you should anticipate 5 days or more. Many patients can get into ortho the same day or the next day, but many parents decline the first available appointment or they have some kind of geographical preference because they don't have the medical literacy to follow your urgent request and they work from home on Friday, so it's better to be seen on Friday. But if you don't think that they can wait for a whole week, then they should go to the emergency room or to urgent care to stabilize the situation. The next one is asking patients to buy DME and discharging them from your clinic without it. Some patients are savvy. You can DoorDash your crutches to the clinic lobby and not even have to walk to your car for some patients. But many patients, it seems they feel like it seems like they have the feeling that if you don't have them, and if you don't instruct them to go to an urgent care to get them before going home, then maybe they don't actually need the crutches that badly. Some patients predict that the cost will be covered if they're dispensed at a follow-up clinic and they don't want to pay retail price for them. But walking around on a non-displaced leg fracture is a good way to increase the displacement. Further, some kids assume that if they don't need crutches now, then if it feels good tomorrow, even though they have an ortho appointment next week, that maybe they can try playing in the football game. The next one is telling patients to ask for antibiotics from another provider. I spoke about this before related to open fractures, but if a patient leaves an ED and then forgets to tell them that their pediatrician astutely noted a break in the skin and the ED resident missed it, then your clinical excellence is essentially wasted, unless they get a call from CVS that their medication is ready for pickup. Patients might come to ortho a week later and starting antibiotics for osteomyelitis prophylaxis related to a wound that's now nearly healed is kind of gauche. I spoke at length about fracture description. Patients come to me all the time without their laterality even specified. It's easy to just leave the final diagnosis as the wrist pain that they initially presented for. But if you make a clear diagnosis and your referral reflects that, then the patient is fast tracked in the ED and in their ortho follow ups without having to redo the history and exam that you already did. You provided the patient with a clear diagnosis and a recommendation to go to the ED for reduction or splinting or whatever they need. So if they come to the ED and their chart or their AVS that they're hand carrying out of your clinic has their diagnosis of right distal radius fracture displaced and closed instead of wrist pain, then they're getting an x-ray, sedation, ortho consult, orthotech, all those things organized much more quickly. So you can help your patients get excellent care by updating and specifying your diagnoses. This is a note from a provider who referred a patient to me. They took the time to take a photo of a knee to show how ugly it looked on their physical exam section of their note. They took the time to upload the media into their chart from their phone, and they took the time in their assessment to venture a guess that the patient's MCL might be injured because of the pain on the medial aspect of their knee and the swelling and the bruising. Their plan is to ask the patient to buy the DME since they don't have it in their clinic, including crutches. They told them to be non-weight bearing, but without any way to prevent weight bearing clinically. Ice packs, Tylenol, and then they placed an urgent referral to ortho, hoping that they're able to be seen tomorrow. The last line in their plan, if not able to be seen by ortho tomorrow, will obtain knee x-ray. So x-rays are for fracture evaluation. This provider has indicated a suspicion for fracture based on the tentative plan to obtain an x-ray if they're not able to be seen quickly by a different provider. But this provider is astutely noting the high risk probability for pretest probability for fracture because of the acute knee pain related to trauma and then the severe symptoms and exam that they've so excellently documented. So they shouldn't discharge a patient without the diagnosis of a fracture or a non-fracture. This patient presented 1 week later to ortho with no DME because they didn't want to pay for the DME and they thought that it didn't matter too much if they were able to get by this week without crutches. And then they were diagnosed with a proximal tibia fracture and they hadn't had any immobilization and they had no awareness that their leg was broken. So again, the best practice here would be instead to obtain the x-ray. The patient would be able to use their clinic wheelchair to transport to and from radiology in the building. Or if you can't get the x-ray before discharge, then have them go to the emergency room or to urgent care so that they can at least have that fracture versus non-fracture diagnosis and get the appropriate DME. The short version behind this photo is a common one. A patient sent an x-ray image to their primary care doctor and asked for some medical advice. This patient was skiing in another country and sent their primary care doctor a message asking for advice on what the next step should be when they return to the United States. The primary care doctor is not able to see them in clinic that week on short notice and is unsure of the acuity or what the patient currently needs. The plan in their note is stat ortho referral. This is a particularly cringe moment, as the kids say, as a recent resident personally. I recently finished all of the inpatient work that we do when we're training for pediatrics. And in the hospital, stat indicates a need on the order of minutes or hours. There's a reason that EMR doesn't allow you to put referral orders with an indication of stat. There's urgent and routine, but there's no such thing as a stat referral. I won't belabor this any further, but to add one sort of final sprinkling of cringe to this, the referral did not specify which bone, the type of fracture, or the laterality, like left or right. The patient starts from scratch when they come to my clinic as if they're in an emergency room, even though they have tried their best to prepare their primary care doctor and make arrangements for when they return home. The theme for both of these cases is a provider hoping the patient can be seen soon, a major factor of the patient's plan. I would say that when you consult ortho or anyone outpatient, ambulatory, you are indicating a medical need of 5 days or more for the evaluation. Many patients can get in the same or the next day with our orthopedics clinics, but many parents decline the first available appointment, or they have a geographical preference that causes barriers, and they may not have the medical literacy to follow your urgent request and take the first appointment or first provider who's available. If you don't think that they can wait a week, then they should go to the emergency room or the urgent care to stabilize the situation. This lecture was based largely on IFE's fracture management, which I'll plug again, and then I include the future reference for our fracture epidemiology from orthopedics urgent care based on the first couple slides. I hope that after this lecture you feel much more comfortable with the scary thought of a patient coming with a broken bone to your clinic. You can go back and pause on especially the remodeling encyclopedia and use it for your own patients. And then you can refer patients to us at Stanford Children's in the Bay Area for any patients that you deem necessary for orthopedics consultation.